Hey you all, Mr. Forney again. This is our part 3 of 4, making up for our snow day on a cold February morning. It's actually evening now. Mary Beth has gone to bed, so no more cameos this time. It's going to be a little change of pace from what we've been talking about. We're going to go and talk a little bit about specimen collection. So in the hospital especially, and really in your primary care office and all the time, we do a lot of diagnostic testing. We draw blood work, we take samples. A lot of the time it's the nurses doing this stuff. It's definitely part of our job description, anywhere from a normal blood draw to different swabs. We all remember those swabs from COVID that had to go deep down through your nose into your nasopharynx and back in here, and they were terrible. I had to get so many of those. But nurses do those. It's part of the deal. We collect stool and urine samples and get people ready for other more invasive tests or different kinds of things. So we are collecting, we're educating, and we're a central part of it. We're also taking that information back and interpreting it as part of our data. So when we do a med pass, we can make sure we know what their values were to make sure they can safely get drugs. I mean, something like, electrolytes, potassium, for example. Was it in range? Was it low? Do they need more potassium? Is this something we need to alert the doctor to? Is this drug we're going to give going to be safe? So this is at the center of our care too. We have to be fluid with this. Now, we don't order any of this testing, but we do basically everything else with it. So you got to know about it. This covers a handful of different student learning outcomes, so it's very consistent with our curriculum. Now, the nursing process, our assessment section. What does the patient know about the test? Do they have any allergies that might be problematic for the test? There's some testing that actually uses chemicals that a patient may be sensitive to. Are there other special safety considerations we need to do? Or infection going on? Nursing diagnoses could be something like impaired urinary elimination or anxiety related to unfamiliar diagnostic procedure, or pain related to a raw sore throat if you're going to do a throat swab. There's all kinds of nursing diagnoses. What's our planning? Make sure you have what you need. Have real goals. Make sure you have things prepared. Schedule your treatments, right outcomes. What's your implementation? Patient teaching is the biggest one here. And then doing the test like you're supposed to, getting consent like you're supposed to, maintain patient safety. Then evaluation. Did you successfully collect the test? Did the patient tolerate the procedure? That kind of thing. So this all ties in with your nursing process. If you think about your ADPI, this is another kind of interesting way to apply it. Before you go in to take your test, whatever it may be, first of all, because we don't place these orders, we need to verify the order. And we verify the order in a very similar way to how we verify medications. We want to make sure we have the right test for the right patient at the right time. Timing can be very important with these. It depends. There are some lab draws that are just once a day, or they may just be when someone comes in for their physical, and then it doesn't really matter what time it is. It's whenever they show up at the lab draw. But we have some that can be as often as every hour even. Very commonly, we'll see every 8-hour tests, or like a vancomycin level draw. We want a trough level usually with vancomycin, so that'll be immediately before the next dose of vancomycin is given. So the timing is important, and make sure you're drawing this on the right patient, because if you have somebody else's values, they're not going to be right. You're going to be working off of wrong information. We need to be prepared with the right education. So know what you're talking about so you can tell them what we're going to do. If it's that nasal swab, you say, look, this doesn't feel good, but it'll be quick. And the sooner we get it over with, the sooner it'll be done. I got to stick this in and basically tickle your brain with it. I got to do a couple little twists and I pull it out and then I'll be done. I promise. It's going to not be fun, but it'll be done. Same thing like with a blood draw. There's going to be a little stick. You've had blood draws before. It's going to be just like that. I'm going to do my best. Get the consent. If it's going to be an invasive procedure, it is the provider's responsibility to get the consent, but you'll facilitate it. So you'll make sure the documents are where they need to be and the patient's able to ask the questions. Physical preparation, depending on what's going on. So like a blood draw, they probably don't really need to be physically prepped. But if they're going for like a colonoscopy or something, they probably had to do a bowel prep beforehand. And guess who gets to facilitate the bowel prep? It's you. Here's the camera. It's you. Actually, one of the proudest moments of my nursing career was we had someone who went for a colonoscopy once and got sent back because she was too much stool was still in the lumen, in the colon, and the provider ordered like repeat soap suds enemas. And so that's what I did my whole shift, is I gave this poor old lady a ton of enemas. But when she went back for her repeat colonoscopy, there was a note in the results that the physician put that complimented the excellent bowel prep. And I felt like that was a little pat on your back, Nurse Nick. It's the little things. That was a very messy, unpleasant day, and I am proud of it, though. You know, that patient got their colonoscopy they needed. So whatever other physical preparation we have to do, we just have to have it together. Some procedures, they need to have an empty bladder. Some they need to have a full. There's all kinds of little details. Follow the orders. We'll often need baseline vital signs, and then address the anxiety. Things like a MRI scan or a CT scan, they have to go into a tight space, and some people really don't do well with that. So we might have to address anxiety depending on what your patient's going into. Even something like a blood draw, if it's on a little kid, can be very anxiety inducing. Now, after the test, depending on what kind of procedure it may be, we're just going to keep an eye on vital signs. Not a big deal if it's something like a swab, but if it's something more invasive like a colonoscopy and maybe they had to go under sedation for it, we got to keep eyes on them. Complications. This could be simple. This could be like you do a blood draw and they're just having more bleeding than you expect, or it could be complicated. They could have an allergic reaction if there's a procedure that used contrast or something. Depending on the procedure, we may want to resume normal activities gradually. Again, if they had to go under sedation for it, we got to take it slow and easy. There's no such thing. It's just a little bit of anesthesia. They're all kind of a big deal. If they did something like a lumbar puncture, we'll need to follow the orders. A lot of times they need to be flat for a set amount of time after something like that, and they may have some pain and discomfort associated with it. If it's like a bone marrow biopsy, that can be uncomfortable. If they're going to go home right afterwards, like I go back to the colonoscopy example, a lot of those are done outpatient, and if they're outpatient, then they need instructions for how to take care of themselves when they go home, and then document how it all went. All right, lab tests. These are kind of straightforward. These hematology, the hematology panel, this is just blood, hematology. Ology is the study of something. Hema is always talking about blood. So our big ones are hemoglobin, hematocrit, platelets, and white blood cells. The hemoglobin itself measures how much oxygen your blood can carry. So a high hemoglobin means you're carrying enough blood. So normal is anywhere from, I think, 13 to 18, or this one says 14 to 18, 12 to 16 for women. So that 13 to 18 ballpark is normal. That means that your blood is able to actually bind to oxygen and carry oxygen all over your body. This is very related to the iron. I think the iron is actually the part of the hemoglobin that reacts with the oxygen to carry it, but that unit is a hemoglobin, I guess. So low hemoglobin is below that. Now, we don't transfuse blood until we get below 8, a hemoglobin of 8. And really, between 7 and 8, the physician has to make a case for why they need to give the blood. Below 7, you'll pretty much always see blood transfused to replace a low hemoglobin, but 7 to 8, the physician will make a case for it. Above 8, most of the hospitals won't even allow blood transfusions at that point. It's just a policy thing. Now, that said, if someone has a hemoglobin of 9, are they going to feel some kind of way? Yeah, absolutely. They're going to feel tired, fatigued, because they're not able to get oxygen to all their cells like they expect. It's not low enough for us to really do anything about it, but it is low enough that you're going to feel bad. Next up, hematocrit. That's the percentage of the blood volume that is red blood cells. This can show how it relates to plasma. I end up working with the hemoglobin more than anything, but the hematocrit runs closely with that. If your hemoglobin is low, often your hematocrit will be low as well. Your platelets, normal is 150 to 400. Low is the big thing I think about is bleeding. So I always check platelets if I give heparin, and we give heparin very commonly in the hospital so that people don't develop blood clots. Now, I will hold and ask the doctor if they still want me to give it if my platelets are below 100,000. And then usually between 50,000 and 100,000, the doctor will still say, sure, go ahead and give them. And under 50,000, they'll usually hold them. But know that the bleeding risk, the lower the platelets are, the more likely to bleed. And when we get below 50, we're even thinking about, like, don't use a straight razor to shave, use an electric shaver, be very careful about any kind of things that can make someone bleed. And when they get down into the single digits, which I've seen working in the blood cancer unit, they can even start bleeding from their gums and their fingernails and all kinds of places. And then a high platelet count is an increased clotting risk, though you don't see that as much. White blood cells, these fight infection. So if you have an infection, your white blood cells are going to go up. That's your body's response to infection. It builds more of these cells to go and fight infection. So what kind of white blood cells are most active can actually tell you where in the infection you are or what kind of infection that you're actually fighting. Low white blood cell count suggests immune compromise. So normal is 5,000 to 10,000. Below that 5,000 suggests immune compromise. In my background, a lot of time that's from chemotherapy that wiped them all out. You might hear something called a shift to the left. When your body's having a severe infection, the bone marrow will actually send out more of the neutrophils, and that's how it ends up showing on here is that's the first one on the left, and the neutrophils will be increased. So we get a big idea for infection with the neutrophils. So the differentials, this is referring to if you see like a CBC with differential or with diff, CBC with diff, complete blood count with diff. The differential is looking at the different kinds of white blood cells you have at a time. And that'll tell you, the differential will tell you which is most elevated. So usually neutrophils are 40 to 60% of your white blood cells. They are the first responders for bacterial infection, trauma, stress, that kind of thing. Lymphocytes are usually 20 to 40%. They fight viruses specifically, and sometimes cancer, they'll be elevated. Monocytes go in and clean up debris and chronic infections. Think longer term illness with this. Eosinophils, more allergies and parasites. So if there's an allergic reaction, this is more likely to be elevated. And the basophils also release histamine and allergic reactions. So these are usually not elevated, but can be an allergic marker. So things to think about if someone has white blood cell count. Remember, normal was what, 5 to 8,000 or something? What did it say? Something like that. And so their white blood cell count is 18,000 and 80% of them are neutrophils. That's probably a bacterial infection. Then if they're 80% lymphocytes, it's probably a viral infection. So you can kind of see some little clues from the differential. Interesting. Coagulation, we have some coagulation specific measurements. These would be particularly useful if we're running like a heparin drip or we're working on getting someone on a anticoagulation bridge. A lot of times we'll start out with heparin because we can, titrate that very easily in the hospital, and we can stop it if we need to go back for procedure. But you can't go home taking those shots necessarily. At least a lot of people can't. We try to get them over to pills. So we pay very close attention to all these numbers. The PT and INR measures the extrinsic clotting pathway. These help monitor your warfarin therapy. Therapeutic PT is 11 to 13, the INR 2 to 3 for most conditions. Then the APTT, that's the activated partial thromboplastin time, measures the intrinsic clotting pathway, helps monitor your heparin. This is one that we will look and will typically titrate based off of if someone's on a heparin drip. Normally that will be out of scope for LPNs, but you'll have to pay attention to what your facility has you do. I've seen some places they'll let the LPNs run the heparin, but like pharmacy will titrate it. I know I've always had to titrate my own heparin, and they have this little table, and you take the APTT and you take some other details, and you decide if you're going to hold it for 2 hours. It's this whole thing. Platelets we kind of talked about, but platelets have a lot to do with clotting. And then your ESR helps measure inflammation. So These can be very useful to know before invasive procedures, so we know our patient's not going to bleed out on us on the table. Urinalysis. These are pretty easy to do a lot of the time. The urinalysis itself, if it's just a UA, those don't have to be sterile or like super clean. We want them pretty clean, but it gets more important when we get to the urine culture that they be like no outside contaminants, period, because we're trying to find exactly what's growing. These can be random or a single specimen, just depends. Like if you are working for a doctor that prescribes like a pain clinic or a mental health clinic and they provide controlled substances, a lot of times they'll have their patients do a urinalysis to test for other drugs to make sure they're not using drugs they're not supposed to. These are also useful if we're worried about a UTI or even like diabetes and this kind of stuff. There's a lot of things we can test from the urine. So random single specimen, that's checking what's in the urine. We will do a clean catch when we need that culture, when we really need a pure specimen. This will actually have them void a little bit and then pause and then aim into the cup and then void their sample out so that whatever was in the pipes gets cleared out first. So that's a little tricky. With these, we want to clean the genitalia first, then do that small amount of void, and then catch the urine midstream in the sterile container if at all possible. That would be the midstream catch. Now, if we need a urine culture and we're unable to get a clean catch like that, maybe someone is demented or uncooperative or whatever, and we really need that clean catch, we can get a clean urine culture from a catheter. We might have to do a straight cath for it, or we could possibly draw it from an indwelling catheter. And then we can do a 24-hour collection of urine as well. These are for checking kidney function, and they'll check like proteins that build up over the course of a day. These, when we do a 24-hour urine, say we started at 8 a.m., we'll have that patient void at 8 a.m. and discard that void, and then we'll start from there, and then it'll run until 8 a.m. the next day. And we'll catch it all, we'll put it on ice, keep it on ice, please. It will get so stinky otherwise. And we collect it all in a big orange jug and then send it down to lab. So what are we looking for with the urinalysis? Color, we talked a little bit about color earlier. You know, if it's dark, they're likely dehydrated. If it's pink or red, there's blood. If it's clear, they're overhydrated. If it's brown, it's probably liver issues. If it's cloudy, it's probably an infection. The specific gravity can tell us about the concentration. If the specific gravity is low, that means we are, I always get this one confused. We are so high specific gravity means it's got more concentrates in it, which suggests that we are dehydrated and don't have enough fluid. If we have a low specific gravity, that means our body has way too much fluid and there's not enough stuff in the urine. So low specific gravity means less stuff in the urine, more water in the urine, basically. High specific gravity means more solutes in the urine, less water compared to the solutes in the urine. So that can kind of help with your fluid volume status and your electrolyte status and all that kind of stuff. Your pH is normally 6 in the urine, so we can check this too. It can be acidic with a UTI and alkaline from other UTIs, so that can be a helpful indicator. Protein should not be in your urine. If you have protein in your urine, that suggests anyways that you have kidney disease or fever or even exercising a lot, and protein's been leaking out through your kidneys. Glucose, also you should not have glucose or sugars in your urine, but it can be present in diabetes when that blood sugar is really high. And ketones should also be negative. Again, the ketones may be present in DKA, starvation, that can be an indicator something's wrong. Blood, you shouldn't have blood in your urine. If you do have blood in your urine, it can suggest kidney issues, trauma, UTI, that kind of thing. And you shouldn't have white blood cells or bacteria in there either. Again, UTI. So your urinalysis can tell you a lot. You think you're peeing in a cup, but it can give you a lot of information. Blood glucose. This is the one we do on the fingertip, typically, at least at the bedside. Finger stick blood glucose, FSBG, we'll sometimes shorten it to. We do this for diabetes. It helps us with our insulin dosing, helps us detect if we have hypo or hyperglycemia. We can do it quickly too. So a lot of the time our patients, if they have diabetes, they'll be ordered for AC and HS blood sugar checks. That means anocomita, so before meals, and hour of sleep, HS. Why it mixes Latin to English, I don't know, but that's how you'll see it, ACHS, before meals and an hour of sleep. Now, if you have a patient who has a rapid mental status change and you're bringing everybody in, think about doing a blood sugar check. That is a simple thing that is quick and cheap to rule out if it's an issue. And if that's the problem, it's an easy fix. You give them some glucose and they're right back in action. So never leave the blood sugar on the table. If there's an emergency, that's something somebody should be checking a blood sugar. We typically do this on the finger. Y'all will get more experience at this in the clinical setting. Normal is 70 to 100, and really any old time, and that's fasting. So you could be up to 140 if you just had a big meal. Over 140 is typically our threshold to start giving insulin when we have someone on sliding scale insulin. So things to think about. Below 70 is hypoglycemia, and we got to deal with that right away. That's give them a little bit of food, like orange juice and crackers. Stay with them, recheck until they're above 70, especially if there's any confusion or altered mental status. That low blood sugar can run away with you pretty quick. All right, blood cultures. Cultures in general are trying to grow pathogens that are grown in someone, typically bacteria, but I bet you could do cultures. I mean, you can do fungal cultures, I think. So the idea is when we're drawing a culture, especially a blood culture, we are trying to figure out what's causing sepsis or bacteremia. And when we know what specimen or what organism is causing this illness, we can bring in the specific antibiotic that fights it best. So the timing on these is important. It'll typically be when it's ordered. Now these are often also ordered as blood cultures ×2, so you need to draw cultures from 2 separate sites so they can make sure they're getting the right organism and they're not getting some kind of contamination or something. Sterile technique is essential. When we do this, we have to really scrub the spot that we're cleaning. We're not taking any shortcuts here. When we do draw, if they're doing aerobic and anaerobic, we do the aerobic one first. That's the one that checks for the bacteria that thrive in oxygen environments. And then we do the anaerobic one. It's supposed to be in order. And then we have to be mindful, if we don't clean it really well, there are common contaminants that'll show up on these if we're not sterile when we do it, and they can cause false positives. A lot of the time the lab will know to look for these and say, no, you got to do it again. But in case one gets through, that would be our fault, and our patient would be getting the wrong antibiotics. Now, these are slow to result. They're typically 24 to 48 hours to get preliminary results, and even longer still. So when the lab gets results, they'll call you, and then you got to notify the doctor. Why they do it that way, I don't know, but they sure do call us first, and then it's up to us to call the doctor. Throat cultures. These are swabs in the mouth. For sore throat, strep throat, tonsillitis, pharyngitis, that kind of thing. You'll get a sterile swab and a culture tube, and just make sure you don't touch the swab. That's kind of the trick. They'll usually come in a container. There will be a tube with a swab on the other side. You open one end and only touch the outside of the swab the throat, then it goes directly into the tube, and you never touch any of the part that actually goes in the tube. That only touched the back of the patient's throat. So tell your patient don't eat or drink before the test, and then don't start antibiotics until after you've done the test. And remember to always tell your patients to take the whole course of antibiotics. We don't want to grow like all the resistant bacteria out there. That's an important concept of antibiotic stewardship. Stool specimens, a fun part of your job. There are a couple different kinds of stool tests. We do an occult blood test. This is a test that checks for blood in the stool that you can't see. Like, it's easy to tell when there's blood in the stool when there's a lot of it. There's even, I saw this one in a chart once, BRBPR, and I found out after a lot of Google searching, and after I asked everybody on the unit, nobody knew, and it was bright red blood per rectum. So if there's bright red blood in the rectum, that's easy to tell just from looking at the stool. But a lot of blood that can be in there can be hidden in there. You know, it can be just a little bit, or it can be partially digested or whatever. And even a little bit can be indicative of something like colon cancer. So we have tests to detect these very small amounts of blood in the stool. We can also test for ova and parasites. Ova are eggs from different parasitic creatures that can set up shop in there. And then we can do cultures in case there's a bacterial infection in the stool. When we collect a stool sample, if someone is ambulatory, we'll put one of those hats in the toilet where we normally have it on the front side to collect urine to measure urine for a woman. We'll have it on the back side, and they'll poop into the hat. And once they pooped in the hat, don't make them do their own sample if they're in the hospital. The instructions say to get a tongue depressor, like one of the popsicle sticks, to scoop it out and put it in the specimen cup. This always grosses me out, but it's the easiest way to get the sample. Go get a plastic spoon out of the break room and just use the spoon to get the sample. It's gross, but that's the easiest way to scoop this poop into your cup. If they're in the bed, we do our very best to not contaminate the stool with urine. Sometimes you got to get creative. This is one, in my experience, you cannot tube stool samples to the lab, so you got to walk the sample to the lab yourself. You don't want to be the person who didn't tighten the lid on the stool specimen and it smeared all down the wall of the tube system. I was responsible for spilling urine down the tube system once. I confess. You don't want to do that with stool, so you generally have to walk stool samples down to the lab yourself. FYI. Radiology and imaging, there's a lot of different radiology. As we talk about different pathologies in the body, we'll talk about more specific imaging, but there are some common ones. So x-rays and radiation through the body, they basically show up differently on different densities of body parts. So these are really good at seeing bones, and they can see like fluid and other issues in the lungs. They are quick. They're not very expensive, which is kind of nice. In the hospitals, they can even roll x-ray machines to the patient's rooms and do a bedside x-ray. Big scan they have is a CT scan. These are more expensive, but they're basically the same thing. It's an x-ray, but it does like a cross section, which is really cool. When we get to clinical and we can pull these up in Epic, it's really fascinating to watch to see all the different angles of the body, and you can see all the different structures and a lot of detail with these compared to a regular x-ray. These are more good for hard structures and that kind of thing. MRI is better for soft tissues. These use magnets. This is one that you really got to be careful. The MRI technicians will not let you get too close to the magnet, but if you ever look up like MRI disasters, if there's anything at all ferrous, that's something that can attract magnets, and it gets near the MRI machine, it'll pull it into it and break anything connected to it. So we have to be very careful with anyone with any metal or metal devices going on with them, pacemakers, prosthesis, aneurysm clips. And MRI will have you do a whole screening before you even send them down to it, but take it very seriously. These are the most powerful magnets you can imagine. Ultrasound is not invasive at all, which is cool, and it doesn't use any radiation at all, so it's good for pregnancy. This uses sound waves to see inside the body. It's almost like a fish finder when you look at it, and it's kind of hard. The X-ray and the CT and the MRI are all things that you can kind of picture the whole body, and when you get pictures, it makes sense with the anatomy, at least for me. But the ultrasound does this weird thing where it's like judging different things by depth, and they really have to be good at their anatomy, the ultrasound techs, to do this, I think. but it can image a lot of stuff. I just had one of these for my abdomen, and they looked at my liver and my gallbladder and my spleen and my pancreas. They said I had a very pretty liver and a very pretty pancreas, and I wonder if the ultrasound tech just thought I was pretty. That's my hunch. We'll see. But kind of cool. And then fluoroscopy, again, real-time x-ray images, but they will use it to guide catheters, and swallow studies are actually really cool. If you ever get a chance to see a result for a barium swallow study, you can actually watch a person live x-ray swallowing this radio opaque, that means it shows up on the x-ray fluid, and you can see it either go down the esophagus, or if they're aspirating, it'll, instead of going down the esophagus, it'll go down the trachea. So you can see exactly where what they're swallowing is going. Contrast is used with these a lot of the time to make things show up better on the x-ray. They may, depending on what they're doing, your patient may have to drink the contrast, or the contrast may be injected into their veins. It just depends on what they're looking at. And the fun part about this is it's a pretty common allergy, so we have to screen our patients for contrast allergies. But the contrast itself is really useful for seeing blood vessels, organs, if there's tumors, that kind of thing. And allergies are the big thing with this. So we're asking for allergies ahead of time. We're watching for reactions after the fact, that sort of stuff. Endoscopy. Endoscopy is just sticking a tube in somebody to see. Endo means going in. Scope means it's basically a tube with a camera on it. So a colonoscopy, they can look at the entire large intestine. They send a tube up through the anus, into the rectum, through the sigmoid colon, up the descending colon, across the transverse, and then down the ascending colon. I got them backwards. So it goes in ascending, transverse, descending, sigmoid. So if it goes, when they send the tube in, it's sigmoid, descending, transverse, ascending. But it can go all the way over to see the appendiceal pouch and everything, which is very interesting. This does require a lot of prep. When they're planned outpatient, they'll usually have to be on clear liquids the day before, and then a very intensive bowel prep the night before, and that's the whole thing. If they're in the hospital, there's a lot of bowel prep that you'll be managing, but they order it very clearly. So as long as you follow the orders, you'll be fine. That patient will be going to the bathroom an awful lot. They will be sedated for this procedure. An EGD, this is basically the other end of it. So they send a tube down, and the EGD stands for esophagogastroduodenoscopy. So that describes exactly where it's going. Esophagus, gastro, so stomach, and then duodenum, that's the very top of the small intestines that they'll go down and image. This is another one that you're typically NPO beforehand for. This one, I would expect everyone should be sedated for that too. And the education for this is that when they come back to, don't be surprised if your throat is sore for the next day after that, because they just tuck a tube down it. Bronchoscopy, that's another tube, scope, but they're sending it down into your lungs to look at your bronchi here. Also NPO, last thing we want is somebody to aspirate into themselves. And we're keeping an eye open for bleeding with this especially. So think, if you stick a tube down someone's trachea that's so vascular in here, I'm worried about airway irritation, and I'm worried about bleeding down my airways. So we're watching very closely for bleeding and any kind of respiratory distress after this procedure. Cystoscopy. What do we think cystoscopy is? So cyst, when we think about the term cyst, that actually defines as a fluid-filled sac. So if you have a cyst somewhere else, it's a fluid-filled something or the other. But it's also commonly how we'll talk about a bladder. A bladder cystoscopy is a scope that they look at your bladder. So in this one, they put a camera tube in your urethra to go and look at your bladder and maybe do biopsies or remove stones or whichever. And then we have ERCP, endoscopic retrograde cholangiopancreatography, where they send a tube in to look at your pancreatic and bile ducts. So that's one again, think about what you're sending a tube in. It's going to go bother those areas. So if I'm thinking ERCP, I do have some concern for pancreatitis afterwards. If you poked it, you might bother it. So things to think about. NPO is very common with these. Follow the orders. And then be mindful, whatever you poked with a tube is liable to be irritated, and that's going to be the main part of your nursing considerations with this. Following the prep orders and then looking for complications related to what got poked and bothered. Now, psychosocial care, people tend to get anxious about this stuff. Is it going to hurt? Know about the procedure before you send it down to them. If this is something you're doing a lot of, ask the provider if you can go down and watch a procedure with them. If you're going to work in an endoscopy clinic, I would think they would bring you along to see all of these anyways, and you'll probably be at the bedside. But if you're in the hospital and you have a lot of patients go for the same kind of procedure, ask if you can go watch so you have a better idea what they're going in for. Anxiety is normal around these. Education is powerful. Sit with them. Hear their concerns, give them factual information, don't speculate. Therapeutic silence can be helpful. Don't say everything's going to be fine, there's no risk with this, but do keep it grounded and say, well, this is what we're doing, this is how it commonly goes, this is what could happen, and this is what we do about it if it would, but I expect this is going to go very smoothly. So take the whole person into consideration. This is what you guys are going to be good at. This is what nurses do. And the education is most important for all of this. Know about your procedures. Know about what they need to do before and after. All right, and here's some scenarios that you could see in clinical. UTI. Nurse collects a clean catch midstream urine, does the urine dipstick testing. It comes back positive for leukocytes and nitrites. And then we send a culture for culture and sensitivity. Then we watch for dysuria, frequency fever. You can pause and read the rest of these. These are good examples of things that you might encounter involving diagnostic testing. And the nurse's role for all of these things. So this is what the nurse is doing with this testing. Because we have a very active role with this. Even though we don't order it, we do basically everything else with it. So pause it, read through these, and I'm going to sign out. I'll see you guys on the next one.